Hello, and thank you for joining me for this educational program on common ostomy surgeries and postoperative challenges. I'm coming to you as a representative of the Emory University WSC program. However, I am currently a nurse practitioner on the colon and rectal surgery service at Yale New Haven Hospital in New Haven, Connecticut. I've been a member of the inpatient team for several years prior to transitioning to outpatient to grow their enterostomal therapy program. It's my goal today to refresh some of the knowledge you have regarding common ostomy surgeries and then discuss some of the postoperative challenges encountered with managing the associated ostomies. We'll also take a look at the products and have an opportunity for some hands-on experiences. Now let's take a closer look at the objectives. These are the goals for this morning's educational activity. We will discuss the low anterior section with ileostomy, total proctocolectomy with J pouch creation and ileostomy, abdominal perineal resection with ankylostomy, and Hartmann's procedure. We'll then look at why it's important to identify whether your patient has a loop or an end ileostomy or colostomy, and how that impacts their management, as well as outline some management options for the patient with an ostomy and review available supplies and products on the market that may be helpful in planning your strategy, as well as appropriate ostomy first aid strategies that you can implement at the bedside while you are taking care of these patients as they recover from their operation. At the beginning of visiting with a patient, I often refer them to the United Ostomy Association of America's website, ostomy.org. This website is a wealth of information with regards to resources as well as support groups for people living with ostomies, and it kind of gives them a place to go and feel that they're not alone and still get some information as well. There are over 750,000 to 1 million people in the United States living with some type of ostomy. And it's noted that 100,000 ostomy surgeries are performed in the United States per year. History of stomas. The earliest stoma that has been found on record was in the early 1700s. It's also worth noting that many patients who had bowel perforations from war injuries wound up with these enterocutaneous fistulas that stomacized themselves, creating their own sort of ostomy. And the early surgical pioneers noted that these patients tend to do much better than those whose injuries were just closed up. They had a longer survival rate. So they took a note from nature, and in 1793, colostomy surgery was done on a 3-day-old infant for imperforate anus, and this patient wound up living till age of 45. You can see here in the mid-1800s, when anesthesia came around, ostomies became a reasonable treatment option for bowel obstruction and rectal cancer. And in the late 19th century, it's noted the first ileostomy used to divert from an ascending colon mass. It's come a long way since these first early surgeries. The techniques have been refined many multiple times by many different pioneers in the field of colorectal surgery, but it's nice to know where things began. And as far as my beginnings, in my year of experience in ostomy clinic, the youngest patient I have seen in clinic is 9 months old. The oldest patient was 99 years old, and the record holder for the longest time with a stoma, was a permanent end ileostomy, is a gentleman who is 84 years young, and he had his stoma for 64 years. And amazingly was still using some of the same equipment that he started with. Let's start to discuss the GI-GU anatomy important to these particular surgeries. The lower GI tract is where we'll start our discussion. The small intestine, the duodenum is the first section of the small intestine where the digestive process is continued and a myriad of different digestive enzymes are introduced to help to break down the food that we have eaten. The jejunum and the ileum are the next sequential sections of the small intestine, and their major function is the absorption of nutrients. The ileocecal valve is a notable gatekeeper between the small and large intestine, and they prevent the influx of bacteria from the colon into the small intestine, which can cause its own GI issues, but it also controls the forward flow and keeps nutrients for a longer period of time in the ileum to maximize absorption. The large intestine is approximately 5 feet. It is comprised of the colon, the cecum, the ascending, transverse, and the descending and sigmoid sections of the colon. As you move along through the colon, you'll note that any ostomy formed from each individual section, the output should theoretically become thicker as you move from the ileum along through to the sigmoid, where you would get really liquid stool from one and really formed stool similar to what will come out of your rectum from the sigmoid colostomy. The rectum is then approximately 5 inches long and the anal canal is 1.2 to 1.6 inches long. Okay, for my visual learners, this is ostomy. I thought I would just take a quick visual tour through the GI and GU anatomy. We start up here with the stomach, which empties down into the small intestine. The initial part is the duodenum, which then empties into the jejunum and then winds up down here in the ileum, down to the terminal ileum, and right here at this juncture you would find the ileocecal valve that then empties into the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and then down into the rectum. Additionally, we'll take a quick look at the GU system, which is somewhat relevant during these procedures. Okay, for my visual learners, this is ostomy. I thought I would just take a quick visual tour through the GI and GU anatomy. We start up here with the stomach, which empties down into the small intestine. The initial part is the duodenum, which then empties into the jejunum and then winds up down here in the ileum, down to the terminal ileum, and right here at this juncture you would find the ileocecal valve that then empties into the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and then down into the rectum. Additionally, we'll take a quick look at the GU system, which is somewhat relevant during these procedures. So now we're going to review several common colorectal surgical procedures that involve stoma creation. The procedures that I've elected to include in this presentation are commonly done here at Yale New Haven Hospital. They're low anterior resection with or without diverting ileostomy, total colectomy with ilioanal J-pouch creation and diverting ileostomy, abdominoperineal resection with end colostomy, and Hartmann's procedure, as well as diverting loop ileostomy and or colostomy, done solely as a procedure itself. The first procedure we will discuss is a low anterior resection. This can be done with or without creation of diverting ileostomy, but for the sake of this talk, we're going to talk about the procedure that does include an ileostomy. Now, the most common indication for this particular surgery is adenocarcinoma of the upper to middle third of the rectum. Most colon cancers, which we have not spoke of here, can be treated with segmental resection such as sigmoidectomy, transverse colectomy, right hemicolectomy, depending upon the location within the colon. However, rectal cancer depends on the location of the tumor and extent of local disease for surgical options. So low anterior resection is the removal of all or part of the sigmoid and mid to upper rectum and total mesorectal excision. This is particularly important as in the case that we're discussing of adenocarcinoma. The goal of total mesorectal excision is to remove the rectal tumor, obviously, along with the pararectal lymph nodes, which are the first area of lymph drainage for the tumor cells, and the preservation of structures outside of the rectal fascia. Most of interest are the nerve fibers that supply the urinary bladder, so help the patient to maintain continence, the prostate, and the vagina, which can affect a patient's sexual activity. Okay, we'll come back to Otto to talk about the anatomy of a low anterior resection. As we mentioned, this surgery is done for mid to upper rectal cancers, and therefore there is a small amount of rectum that is preserved. Otto is a little less flexible than I would like, so we need to imagine an anastomosis from this point of the colon down to the remaining portion of the rectum. As you can see, a diverting loop ileostomy was brought up to the surface of the skin to allow for the stool.
Okay, we'll come back to Otto to talk about the anatomy of a low anterior resection. As we mentioned, this surgery is done for mid to upper rectal cancers, and therefore there is a small amount of rectum that is preserved. Otto is a little less flexible than I would like, so we need to imagine an anastomosis from this point of the colon down to the remaining portion of the rectum. As you can see, a diverting loop ileostomy was brought up to the surface of the skin to allow for the stool stream.
An abdominoperineal resection with colostomy is another procedure that is commonly done in our surgical service. The indication for this is a low-lying rectal cancer, which is close to the sphincter complex or with sphincter involvement. It also requires total mesorectal excision, similar to the low anterior resection, and the resultant ostomy is an end-sided left sigmoid colostomy, usually, depending upon the patient's internal anatomy. Oncologic resection for both LAR and APRs are a little bit more involved than those types of surgeries for different reasons. Tumors of T3 or greater, or any tumor node with METs, those patients usually undergo neoadjuvant, which means before their definitive surgical treatment, chemo and radiation. And depending upon the final pathology from their surgery, the adjuvant chemoradiation may be added if there was found to be more lymph node involvement that was untreated by the initial round, and or they are found not to have clear surgical resection or clear margins that are free of cancer cells.
We can now take a look at Otto to understand what happens during abdominoperineal resection for low-lying rectal cancer is the most common indication. And as you can see here, what the surgeon will do is remove the lower part of the sigmoid, the entire rectum, and the anal canal. The patient's perianal area is sewn together, and then a loop of the large intestine, most commonly the sigmoid, is brought up to the abdominal surface and an end colostomy is made.
The next procedure we can discuss is total colectomy with ileoanal J-pouch creation and ileostomy. Common indications for this particular procedure are familial adenomatous polyposis and ulcerative colitis, largely these diseases that are confined to the colon. So most patients who have Crohn's disease are not a candidate for this particular surgical treatment. These procedures can be done in 1, 2, or 3 stages, completely dependent on the comfort of the surgeon, health status of the patient, and any presence or absence of active disease. The ileal pouch is created from a piece of ileum and formed into a J-type shape. This creates a new reservoir for stool because in this procedure, the entire colon is removed along with the majority of the rectum. However, there is retention of the rectal cuff and the anal sphincter mechanism, which allows the patient to maintain their natural continence function. So we talked a little bit about active versus non-active disease. If there is no active disease, a one-stage procedure can be completed, especially if the patient is not on immunosuppressive drugs and there's no tension noted on the ileal pouch during surgery. But diversion is done if any chance of an anastomotic leak or dehiscence due to tension on the J-pouch and rectal anastomosis. High-risk patients may be done in 3 stages. And those include those patients with medically refractory disease, particularly ulcerative colitis, malnourishment, and a long-term immunosuppression. The rectal stump is left in place in the first step of that 3-stage procedure and often allowed to heal as it will without stool passing through it on most occasions. These patients are then brought back to the OR for the J-pouch creation, and then they're brought back to the OR one more time to have the ileostomy taken down.
For a total colectomy with ileoanal J-pouch creation, the entire colon is removed, as well as a small portion of the rectum, leaving a rectal cuff, and a J-pouch is then created. The J pouch is created from a piece of ileum that is sewn together in a J formation and utilized as a new stool reservoir. To protect that reservoir in the anastomosis where it is healing to the rectal cuff, the stool is diverted through the creation of a diverting loop ileostomy, again bringing a loop of the remaining ileum up to the abdominal wall and creating a loop stoma, again with two openings, one for stool, one for mucus that is connected to the lower GI tract.
Hartmann's procedure is usually done for surgical need due to gross perforation, most likely from diverticulitis. An anal and rectal stump remain after surgery in the diseased portion of the colon. Again, most likely the sigmoid is removed. The stump is closed with surgical staples. The resultant stoma is usually located in the left lower quadrant, and there's a high likelihood that the ostomy can be reversed once the intra-abdominal sepsis has resolved and adhesions have softened.
The next procedure we'll look at from an anatomic perspective is the Hartmann's procedure. This procedure, as we talked about, is most often indicated for perforated acute sigmoid diverticulitis. The sigmoid is removed, or the diseased proportion of the colon is removed. A rectal stump is left in place in anticipation of future reconnection, but is closed off, and the surgeon will then bring a piece of the sigmoid intestine up to the abdominal wall for the creation of the next procedure we'll look at from an anatomic perspective.
I know I promised 4 surgeries, but I couldn't let this go without discussing just the plain diverting loop ileostomies or colostomies that are created for the purposes solely of the diversion of stool. Their location depends on the level of obstruction, perforation, mass, or tumor, which is the reason why the patient may need the stool stream diverted. These are patients who are not candidates for immediate resection of the diseased part of the colon, and it allows them to have continued GI function, either while completing the workup for obstruction, while completing chemotherapy, and or these are now being done more frequently for palliative procedures so that patients who have tumors that are either intraclonic or compressing their GI system from the outside of the colon and or small intestine can have maintenance of GI function as well as resolution or somewhat control of nausea vomiting that is the result of an obstruction.
Sometimes there is a need to create a diverting loop colostomy and or loop ileostomy above the level of an obstructive mass and or a newly created anastomosis that may have an anastomotic leak, to give the area time to heal if in the case of an anastomotic leak, and or to give the providers additional time to work up a newly identified mass and or stricture of part of the intestines. The loop means that a portion of the bowel, again, is brought up to the abdominal wall. Sometimes there is a need to create a diverting loop colostomy and or loop ileostomy above the level of an obstructive mass and or a newly created anastomosis that may have an anastomotic leak, to give the area time to heal if in
So loop versus end stoma, and why does this matter? It's important that before you go in to evaluate. So now we'll look at loop versus end stomas, and why does this matter? It's really important for you to have an understanding of what type of ostomy your patient has. An end stoma, you're looking at one opening to pouch. It's less likely to be temporary, but these can be reversed. Loop ostomy, there are two open areas that need to be pouched. and they may initially have a support bridge, which can present another pouching challenge. The intention of these stomas is to be temporary, although some, especially if done for palliative measures, can be permanent. It can create a pouching challenge if the distal loop is hidden, as you can see in the picture over to the right. The distal loop is compressed and very small, and this patient has a lot of excoriation around the opening because the visiting nurse at their house did not realize that this was a loop stoma and was not looking for the second opening. The distal limb continues to be productive of mucus, just as the proximal limb continues to be productive of stool, and particularly with ileostomies, both of these effluents contain digestive enzymes which can contribute to the breakdown of the peristomal skin, which is what makes this very important to identify from the beginning. And one other reason for the loop ileostomy too is in a case where we're looking for reversal, the surgery is less complicated than that of a loop colostomy or an end colostomy or ileostomy. So as a patient, what am I looking for overall goals of ostomy care? I'm looking for a pouching system that can afford me reliable stool containment for a predictable wear time. Patients want to have confidence and comfort with emptying the particular pouch and changing that pouch, and it's very important for them to maintain intact peristomal skin, to promote pouch adherence, and to maximize their capacity for self-care in the instance that someone may have a deficit such as a visual issue and or reduced capacity for fine motor skills, where they might find a particular pouch to be a little bit more user-friendly than a different kind of pouch. So it's important to kind of be familiar with what is out on the market and what accessory products you can use. Although I am a firm believer that less is more when it comes to ostomy products. There are instances where all the accessory products or some accessory products are what is the needed remedy to a particular pouching situation. So let's take a look at some of the ostomy care products out in the market, most of which I'm sure you've seen, considering that this is a colorectal surgery floor. There is the solid skin barrier, which is the wafer that sits in between the ostomy pouch and the patient's skin around the stoma. Its function is to protect the peristomal skin and secure the appliance to the skin. And this barrier is either integrated into a one-piece pouch or separate from the pouch as in a two-piece pouch. The rest are accessory products which can be used if needed. Paste is used as caulking to fill in minor skin wrinkles or skin defects, divots. And just a little tip with the paste, you can use a moist glove finger to smooth it out if you're having issues with getting the paste to be in the location that you'd like it to be. Sometimes these paste products can contain alcohol, which patients may find irritating to skin, especially if there is a little bit of skin breakdown in the immediate peristomal area. Powder, on the other hand, is a hydrocolloid, and it is used to absorb moisture of denuded peristomal skin. So if you have weeping skin around the peristomal area, stoma adhesive powder might be one of your first go-tos. That being said, you do need to have a barrier spray and or barrier pads to help hold the stoma powder in place. We'll get to that in a little bit when we're discussing ostomy first aid. There's also barrier rings or seals. Sometimes these can be used to create soft convexity for a patient who has a flush and or retracted stoma. Somebody who is immediately post-op who you don't really want to put in firm convexity just yet. They can also be used to fill uneven skin and improve the skin seal. And the barrier or the paste strips are used for similar things as the seals, but you can break off small pieces to fill uneven skin, and these products don't contain alcohol, so they can be less irritating to the patient. The elastic barrier strips, I found they were initially designed to improve the seal on the outside edge of the solid skin barrier. But they can also be used under the wafer to secure dressings in place if needed. Although the companies that have created them have told me that this is not one of the approved uses, I found it to be very useful in holding a hydrofera and or alginate product in place. And liquid barrier film is an additional protection for the skin. It's not something that needs to be used on a routine basis, and as a matter of fact, there's a few solid skin barriers that may not adhere as well with routine use of the liquid barrier film. However, it is very useful when you're looking to heal denuded skin and to secure barrier powder or ostomy powder in place. As you can see, the solid skin barriers come in various constructions from flat to convex, from cut to fit to pre-cut to ceramide infused, flexible, firm, soft, deep, and light. Hopefully we will get a chance to play with some of these later today. Flat versus convex is taken into consideration after examining the surrounding peristomal skin while the patient's lying, standing, or sitting. If the area around the stoma remains flat, a flat barrier should be sufficient, and you should be able to use that. Convex can be used for varying amount of curvature to the peristomal skin. If there's a lot of creases and folds that exist, convex barriers can help keep the peristomal skin flat. The depth of the barrier should be matched to the depth of the creases. As you can see here, there's soft, deep, or light convexity. And it can also provide counterpressure as needed to maintain a seal. That is the area where it is sometimes people are hesitant to use convexity immediately post-op, especially firm or deep convexity, because there's a theoretical risk for incisional and or peristomal skin breakdown due to the pressure of the convexity. Convexity can also assist with stomal protrusion in the cases of flush or retracted stomas, or if the lumen is off to the side or close to the skin. So whereas the barrier seals used to be used often to create convexity, now that they have convexity built into the back of a pouch, the barrier seals can still be used, but they are needed less. Cut to fit versus pre-cut depends on the size of the stoma. It does change over the post-op period, so it may make more sense to be in a cut to fit pouch initially. The stoma usually arrives at its final size somewhere between 8 to 10 weeks post-op. Cut to fit may also be more useful for irregularly shaped stomas, or if you need to offset the stoma opening for any reason, such as an abdominal incision or any other wound that may be on the abdomen that you would not want to secure a pouch to. Pre-cut is a way to simplify stoma care once the stoma has arrived at its final size and other abdominal issues may have resolved. It's also very helpful for a patient who might be elderly or other people with dexterity issues where continually cutting a barrier may be a problem for them. And these should be considered when the stoma size is not thought to change anymore. Ceramide-infused barriers are said to help support the natural function of ceramides within the skin. And so patients who have very sensitive skin or having a lot of peristomal issues may benefit from ceramide-infused barrier. There's only one company on the market right now that has the ceramide barrier on its formulary. Flexible versus firm convexity. Flexible can bend and move with the body, whereas firm does not bend. So if you have a soft abdomen, it might be more advisable to consider a flexible convexity so that the barrier or the wafer, depending upon what you're using, does not pop off. So the other question is one-piece versus two-piece pouch construction. For one piece, a lot of people feel like there's a single seal. It gives patients a sense of security because there's no risk of detachment between the pouch and the wafer. In theory, once patients get used to using a two-piece pouch, I think the risk of separation becomes much less. However, in the initial period, as they're getting used to their stoma, this may be of concern to them. It also can be difficult to place a pouch over a stoma if the one piece that is chosen is an opaque pouch, because it's difficult to see through. Of note, most of the peekaboo windows can be cut away in the initial post-op period if the opaque pouch is the one that the patient feels comfortable using. However, if able, it would be recommended to use a transparent pouch for post-op learning. Patients with the two-piece construction, who prefer the two-piece construction, I find like being able to see the stoma when they would like to, so they can separate it at the same point where people are nervous of the barrier and the pouch becoming disconnected. They can disconnect it intentionally and take a look at what the ostomy is doing and what it looks like. It's also a way that they can clean the pouch, and it's a way to change the pouch without removing the skin barrier. So whereas most skin barriers are thought to be able to stay in place for 3 to 5 days, with one piece or two piece, with the two piece, you can leave the skin barrier in place for 3 to 5 days. But let's say somebody who has an end colostomy with 1 to 2 bowel movements a day, they can just switch the bag, change the bag when they have a bowel movement instead of having to change the wafer. There's also the question of drainable versus closed end. We kind of just discussed a little bit about that. Drainable is more suitable for patients who have liquid stools, such as those with end ileostomies, where they're emptying the pouch more than once or twice a day. Closed end pouches are good for low output stomas, where they're emptied once or twice a day, or patients that irrigate that just need something to protect the stoma in case something escapes during the day. Just a note quick on Medicare allowables for patients. Right now, Medicare is allowing 20 drainable pouches per month and or 20 wafers and 60 closed-end pouches per month. With those closed-end pouches, they will give you an amount of drainable pouches in the event that the patient has a stomach bug or stool has changed more liquid due to maybe chemotherapy treatments. So there are allowances made within that for patients with a gastroenteritis. So when you're looking at your patient teaching, you want to look at pouching, and you want to make sure that when they're leaving the hospital, they feel comfortable emptying their pouch. They should be emptying their pouch when it's a half to a third full. They should feel comfortable with opening the pouch to empty it and or cleaning and then closing it back up. They should be familiar with indications that the pouch needs to be changed. For example, if the stoma itself or the skin around it feels uncomfortable in any way, it can be indicative of a leak that's starting to happen at the point of the ostomy. So the pouch really should be changed, as well as the need to just be able to change it on a regular scheduled basis, whether that be 3 days, 4 days, or 5 days, whatever their wear time is found to be. They also should be encouraged to make a checklist, especially in the initial learning stages, of equipment that they need to do a pouch change, kind of talk through where to do it within their household, and what it is they need to bring with them in order to make it successful, so they're not thinking about what they forgot in their bedroom if they're in the bathroom, or vice versa. They want to get used to examining the skin and noticing any skin issues early, because they're always easier to treat on the earlier side than when it becomes more of an issue. And they want to be comfortable initially in the first postoperative period with measuring the stoma. They should be given several measuring guides and or taught how to use a measuring tape if it's an oval stoma, so that they can continually keep an eye on having the right size opening for their pouch. This is important because even the slightest deviation from that 1/16, 1/8 inch of exposed skin can cause the stool to get underneath the barrier and erode the wafer, the adhesion from the wafer. They also want to be familiar with skin cleansing, which should be a very simple routine. They don't need any special products. Preferably, it should just be warm water. If they would like to use soap, it should be soap without any emollients or alcohol that might interfere with the seal of the pouch after cleaning. And then they should be taught the push-pull technique for removal, where as they're pulling the wafer against or away from their skin, they're also pushing down on the peristomal skin to reduce mechanical trauma. If they still find, as some pouches tend to adhere very well to skin, that is their function. But if they find that they're having a hard time getting the pouch off, there are adhesive removers on the market that can be bought in spray and or pad form. And they should be taught when to seek assistance, when the peristomal skin becomes an issue, when they're not able to keep a pouch on for a predictable period of time, when they're having a lot of leaking, if their output tends to be much higher than it usually is, and they're at risk for dehydration. All of these things kind of we're trying to cram into a 3 to 5 day hospital stay, depending upon why they have their stoma. Additional considerations for them: where and when to obtain supplies. It's important for you guys to know that patients often that are discharged under VNA care, depending on their insurance, cannot order supplies until they're discharged from the VNA. So as long as they're under the VNA care, they're coming to their house, they're helping them with pouch changes, the VNA needs to order their supplies through their supplier, and then they should help them set up with a company before they discharge them from their care. And they should be comfortable with bathing and showering. You should know that clothing is a concern for a lot of people. They get very nervous that somebody's going to be able to see their stoma through their clothes, and most often you have to make minimal, if any, changes to your wardrobe after you have an ostomy. Dietary concerns are also an issue, especially when it comes to ileostomies and food blockages. We ask them to stay on a low-fiber diet for a period of weeks after surgery. And when we say low fiber, it should be insoluble fiber, like the fiber that is found in the skins of fruits, the fiber that is found in celery and raw vegetables, salads, a lot of lettuce, because these can kind of congregate at the exit of the ileostomy until the swelling goes down from the initial surgery and cause a blockage, which then causes a myriad of unpleasant symptoms like abdominal pain, nausea, vomiting. And they should also know that there's available outpatient support here, especially at Yale New Haven Hospital. We do have our outpatient ostomy clinic that is available to them 2 to 3 days a week. And we are trying to formulate our own support group here, but there are local support groups in Waterbury and up in the Hartford area that they can hook up with to get any support that they might need. So I thought maybe we could spend some time on ostomy first aid. One of the most common skin conditions is denuded skin, and this can come in the form of a variety of different things. One of the most common is irritant contact dermatitis, and what does that mean? That means that some way, shape, or form, most likely anyways, that the stoma output has found its way underneath the barrier and been allowed to sit there for a period of time, where the digestive enzymes from an ileostomy and or just the contents of the stool have started to erode the top layer of skin. It can also be an allergic contact dermatitis, although it doesn't happen often. There are patients that find that they have an allergy either to the adhesive and or the properties of the hydrocolloid, so a lot of times by changing companies, they find that their skin clears up. What do you do for this? If you walk into a patient's room and their ostomy is stinging and their pouch is off and the skin looks red and raw and like it hurts, you can cleanse the peristomal area with just warm water. If the patient insists, you can use a mild soap. Let the area dry. Spread powder on the denuded skin, so just plain ostomy powder, and brush off any of the excess using a gauze and or a tissue. The powder will stick to irritated and weeping skin. And then if you have available to you the spray powder, or the 3M Cavalon barrier spray. You can use that and or dab with barrier wipes to help the powder to adhere to the skin. And then make sure you have the right size pouch, so measure the pouch opening size again, make sure the stoma hasn't changed in size, and apply the pouch. And hopefully over the course of the next 3 to 5 days this will clear up. If you catch it early enough, it clears up really fast. An additional thing you should be aware of is what a fungal rash looks like. Most of us are familiar with this. So you can also crust with antifungal powder. This is the fungal rash presents with usually a central lesion that is red and irritated looking in nature, but it also has these little tiny satellite lesions, the tiny pink dots that you see around it. And what you can do to help treat this is to request a prescription for nystatin or meconazole powder from a provider. Again, you're going to cleanse the peristomal area with warm water mouth soap, and you're going to crust very similar to the way that you just crusted the stoma powder, using spray, barrier spray, and or barrier wipes to hold the powder in place. It's been my experience that very infrequently do you need to progress to a systemic antifungal in order to treat a skin rash. Additional issues that you may encounter, minor mucocutaneous separation. As you can see in the top picture there, there's a little bit of a separation between the stoma and the regular peristomal skin. So the mucosa has separated a little bit from the skin. You can fill that defect with ostomy powder to absorb the drainage and then crust the powder in place with the barrier spray. The mistake that I see a lot of providers make is they try to make the pouch opening bigger, and that can make the problem worse. You do want to place the pouch over the area of MC separation to secure the powder in there and also to protect the juncture that is trying to heal. The major mucocutaneous separation you can see here on the lower picture. You can fill that with an alginate dressing to absorb the drainage. If you have it at your disposal, you can use the elastic barrier strips to hold the alginate in place and then place the ostomy only over the mucosal tissue. So again, make sure that you cut the ostomy opening only so it's large enough for the mucosal tissue to be exposed. If it is a large defect, providers may want to try a vac, and then you just apply the pouch over that. There are a few situations you might come across that may need or seem to need a little bit more than first aid. The first picture on the left is a dark and dusky stoma. You are taking the pouch off for the first time and this is what you see. It can be a little bit unsettling. And it's necrotic tissue. A lot of times there may be some yellow slough on top as well. If you are able to notify the provider and have them come evaluate it with you, most of the time they will note that there is some pink underneath the top layer of necrosis, and what that usually means is that the top tissue of the stoma will often slough off and underneath will be nice healthy pink tissue. It is definitely something to keep an eye on. The middle one is a prolapsed ostomy. I think this is more disconcerting than anything. It is more common in loop stomas, especially in the distal limb. It's usually not an emergency unless the patient is presenting with some sort of obstructive symptoms, like nausea, vomiting, increased abdominal pain. But a lot of times they're just more psychologically freaked out because they not only have this new stoma, now it is twice or 3 times the size that it initially was. There are methods that they can be reduced at the bedside, may be more comfortable with this being done by a physician or LIP, like a PA or a nurse practitioner, but largely by osmosis. If you put sugar over it, sometimes it shrinks the stomal tissue and it will just slide back into place. The ostomy powder sometimes does have the same effect as well. And once the stoma is reduced, it can be supported by an abdominal binder until you have the opportunity to get a prolapse belt for the patient. Sometimes, if this is intended to be or happening with an end stoma or something that somebody is supposed to have for a long period of time, the surgeon will revise it, or if it's something that happens multiple times a day and is just a major inconvenience for the patient. But most of the time, like I said, it's not a surgical emergency. However, all the way over to the right, you will see that this is another picture of a necrotic stoma, which is also prolapsed. But the stoma here very obviously has a deep disruption to the perfusion and is compromised. And this is an emergent issue. It needs to be brought to the attention of the surgeon and our covering provider immediately, and most likely fixed surgically. Just throwing some ideas up there about when you need to notify the doctor or the LIP, or teach your patients to notify the doctor or the LIP if they're home at this point in time. So any prolonged abdominal pain, nausea, vomiting, or distension could be indicative of an obstruction. Especially if they have an ileostomy, they want to pay pretty close attention to it because they can become dehydrated really quickly. Colostomy patients, if they have no output in 2 days, it may be as simple as calling the doctor and having them add a stool softener or Miralax, but they still should let somebody know. Ileostomies, no output in 8 hours, also accompanied by the above signs. You will rarely see no output from an ileostomy, so that is a sign of concern. Urostomies, no output in 6 hours, although this is a GI-focused course. Any excessive thirst, concentrated urine, weakness, lethargy, or fecal output greater than 1,200 milliliters in 24 hours, which again is most likely with an ileostomy and can be indicative of dehydration. And the last one is specific to urostomy. What I want you to take away from this is really the struggle is real. A lot of these patients are scared. They don't really know what having an ostomy is going to mean to the rest of their life if it's something that they're facing on a permanent basis. Most often, hospitalization is just the beginning of their self-care learning curve. And they have somebody there, at least we have specialty nurses in addition to staff like you who have additional training in taking care of stomas. While they're in the hospital, they have the additional support. And they do have visiting nurses who come to their home, or if they happen to go to a short-term rehab, they have the nurses and or medical staff there. However, most of those places and a lot of the VNAs are struggling to keep a certified ostomy nurse and or stoma nurses, or staff nurses who have a lot of exposure to caring for ostomies on their staff. And so this is a difficulty that a lot of patients encounter. Especially for ileostomy patients, you'll note that they can be prone to returning to the ED, and some are rehospitalized. This is for many reasons. Some have let their peristomal skin issues go way overboard, or pouching problems before they've sought help. Others are for dehydration, and some for obstruction. But this is something that people can really struggle with. So try to have some patience with them and let them know what their resources are once they're out of the hospital. Just looking at study quick, there was an incidence of stomal complications in 21 to 33% in a few studies that I looked at. And there was one study that showed peristomal or stomal complications, which are things like skin, leakage issues, prolapse, up to 63% in the first 3 months. That was a small study and it seems like a high number, but this is obviously an issue for people. And along those same lines, this is a young patient, Keegan Lingard Hassel, who is an ostomy advocate with the United Ostomy Associations of America. I apologize for reading this to you, but she was writing in regards to home healthcare providers and her experience where she had somebody walk in and immediately say to her, well, it's been a while since I've looked at a stoma and I really don't have very much experience. But I think we can apply this to all healthcare providers. And her quote was, I want to encourage home healthcare providers to meet each of their ostomy patients where they're at. The physical and emotional healing timelines differ from person to person. One thing to consider when trying to support your patient is your demeanor. Don't act intimidated or scared. As a patient, it is reassuring when our caretakers appear confident and accepting of our stoma. Your attitude toward patients or their ostomy can strongly influence the way the patient adjusts and may impact their journey toward acceptance. So I think the important takeaway from that is, even if you walk into their house and this is something you haven't seen in a while or something you don't have a lot of experience with, reassuring them that if you guys can't figure it out together, that you have resources and other staff in your agency that you can turn to that will help you to troubleshoot this. Even in the hospital, we see things all the time that we've never seen before. And you never want to be the patient on the receiving end that, oh my God, what is that? So just be kind. I know this has been a lot of information that I've thrown at you over the last 45 minutes. I would love to take any questions that you may have at this time and throughout the next little bit of practice, hands-on practice time we have. Okay, now it's time for playtime. We're going to look at crusting technique as well as break into 4 randomly assigned groups to participate in a pouching challenge. Each group will be assigned a particular stoma, supplies will be provided, and your care plan will be discussed with the group after about a 15-minute time period. Try to have some fun, be creative, and remember what we've learned about the different supplies today.
In the instance that you want to help your patient implement crusting as part of the plan of care for their stoma for either some peristomal skin irritation, denuded skin, and or some mucocutaneous separation, you will need 3 things. You need Cavalon spray and or barrier wipes, ostomy powder, and a tissue or a piece of gauze to wipe off the excess. And the procedure goes like this. You can fill in the defect with some ostomy powder, and if we pretend that there is some peristomal skin breakdown on this side, you would then take a tissue, dust off the excess, use the spray. In the instance that you want to help your patient implement crusting as part of the plan of care for their stoma for either some peristomal skin irritation.
Okay, now it's time to break into our groups, and we're going to be confronted with several case scenarios and then share. Each group will be assigned 1, and we will share our pouching thoughts with the group after each challenge is complete.